on Facebook. Good afternoon, everyone. Thank you for joining us. This is our Facebook Live event called Ask the Docs series. And this is a live 30-minute question and answer session where Dr. Rogers and I answer your questions on regenerative medicine and using PRP and cell-based therapies for various orthopedic conditions. So our topic today is specifically on the use of these therapies for joint osteoarthritis. So you can go ahead and type away your questions and we'll answer them as they come. I'm joined by Dr. Rogers, who is the founder of San Diego Orthobiologics Medical Group. I'll let you say hi, Dr. Rogers.
Good afternoon, everybody. Thanks for joining us today. I'm Chris Rogers. We're here in Carlsbad, and we'll be answering your questions. So just to orient you, for those of you who are not familiar, if you look at the bottom of your screen, you'll see there's a Q&A option where you can type in your question, and we'll do our best to answer as many as possible.
So why don't you define osteoarthritis, Dr. Rogers?
Yeah, osteoarthritis is a specific type of arthritis, a condition that affects the joints. And in the past, we used to think it was due to just wear and tear of the cartilage in your joint. Now we understand it's much more complicated than that. It's best characterized as a chronic inflammation of the joint, where the immune system is actually attacking some of the tissues, not just the cartilage, but also the bone and the lining of the joint. It's extremely common. There's about 30 million people in the United States with osteoarthritis and about 250 million people worldwide with diagnosed painful arthritis. It most commonly involves the knee and the hip, but it also commonly involves the thumb, and then shoulder would probably be fourth. And it's something when you get to my age, over 50, that you're likely to have at least one joint that has this condition. It's not a disease per se, although it can be extremely debilitating and have serious impacts on your overall health. For example, knee osteoarthritis has been associated with coronary artery disease and actually death from cardiovascular causes. And that's probably because you can't exercise as much as you would like to, and maybe some other reasons as well. And so osteoarthritis is something that's been around since the beginning of time. If you go to your friendly museum and look at the mummies, you know, the CAT scans of the mummies show that those poor folks had arthritis as well. We're not exactly sure what causes osteoarthritis. Oftentimes it's a traumatic event. So, you know, a football player, somebody twists their knee and they injure the cartilage, and then it starts progressively becoming inflamed and degenerates over the decades. It's probably true with the rest of us as well, where it's some microtrauma, repetitive microtrauma, overuse of a joint is commonly associated. Obesity has been associated with osteoarthritis. And surprisingly, exercise is not. Exercise is actually protective. We used to tell people that if you're a runner, that you're more likely to get arthritis, and the truth is actually the opposite. If you're a runner, you're more likely to have healthy, strong cartilage, although they get arthritis too. And we see a lot of runners with knee osteoarthritis. So how do we treat it?
So the standard treatment for osteoarthritis is something that a lot of you who have osteoarthritis has probably undergone before you even came to see us. And that includes therapeutic rehabilitation or your physical therapy, some anti-inflammatory medications, maybe some analgesics if you have a severe flare-up of the pain. If those fail, then the injection therapies like steroid injections can help give temporary relief of the pain and inflammation. There's also other injections like hyaluronic acid or HA, which is a viscosupplementation or a gel cushioning for your knee that helps with osteoarthritis. What we are talking about today is using cell therapies like PRP, platelet-rich plasma, and cell-based therapies that are derived from your bone marrow and from your adipose tissue or fat tissue to treat osteoarthritis. So very briefly, platelet-rich plasma, or PRP, as most of you know, is a very concentrated amount of platelets, which is the cells in your blood, more than what your body concentration is. It typically is anywhere from 3 to 5 times your normal body concentration, even more in some cases. And we are interested in these platelets because they contain thousands of growth factors that are involved in tissue repair, healing, regeneration, analgesia or pain relief, inflammation, which are all designed for long-term pain relief as opposed to steroids, which is short-term. While cell-based therapies are a different subtype of cells that are derived from either your bone marrow or your fat, and they contain stem cells, specifically called mesenchymal stem cells, which are cells that not only has the ability to replicate themselves, but they can also differentiate into other tissues that your body needs. For example, bone, muscle, ligament, cartilage tissue. So that's what we wanted to focus on today. And let's get on to the questions, Dr. Rogers.
Yeah, so
There's
looking at some of the questions, and I appreciate your questions, and keep them coming, guys, because we still got time to go through them. One of the common questions I get from patients, the same question that I'm seeing coming up here in this forum, is, trying to differentiate between platelet therapy versus stem cell therapy. And these are extremely complicated topics. However, I will just boil it down by telling you that platelets, as Dr. Ambach said, they come from your blood. We used to think that their only function was to clot blood, right? So if you cut yourself, it stops the bleeding. But in addition to doing that, they release these growth factors, which have been shown to be advantageous for decreasing inflammation in the joint and also stimulating healing. They don't stimulate healing in and of themselves. They do that in collaboration with other cells in your body. And one of those cells you have in every tissue in your body is the stem cell. But even that is extremely complicated because the stem cell is not a single cell. There are many different types of stem cells. When we talk about the mesenchymal stem cell, the MSC, the one that was first described in humans back in the 90s, that was originally discovered in the bone marrow. And then later it was discovered in fat tissue, and then later other tissues. And the reality is this particular MSC, the mesenchymal stem cell, is in every tissue of your body that has a blood vessel, because that's where they live. Those little MSCs live on your blood vessel, but they do not turn into cartilage or bone. They can, but that's in the lab. If you take the cell off the blood vessel, put it in the lab, you can turn it into a cartilage cell. That's no problem. But in your body, they're functioning differently. They're actually in a lot of ways functioning like a platelet, in that they're releasing growth factors, different kinds of growth factors that will stimulate yet other stem cells in your body to grow. So now we have at least 3 cells we're talking about in your knee joint. We have a platelet cell that's releasing growth factors. We have the MSC, mesenchymal stem cell, which is also releasing growth factors and cytokines and something called exosomes and et cetera, et cetera. And then you have the native stem cell in your joint that can turn into a cartilage cell, for example. And they're all talking to each other. So you say, well, when would you use one and when would you use the other? In general, we use the platelets for the milder conditions because it's been shown that that's effective for milder arthritic conditions. So if the cartilage is not too severely damaged, if your meniscus is not too severely torn, if your joint's not too severely inflamed, the platelets, the PRP will work very well for that. Whereas if it's a more robust type injury, if you had it for a longer period of time, people talk about bone on bone knee arthritis, where the cartilage has worn so thin that now the bone surface is exposed. Those are more serious cases. Some of those need surgery, frankly, but a lot of them can be managed by using the mesenchymal stem cell, the MSC, which we find in bone marrow in small amounts, and then we find in larger amounts in fat tissue. So I just want to differentiate. I know it's really complicated. The biology is still being discovered. I mean, 50 years we've been talking about stem cells and we're still just figuring it out.
Yeah, that's a pretty good explanation of that topic, Dr. Rogers, and I think they had a pretty good idea of what these cells are. There are several questions on the difference between an adipose tissue or a fat tissue as a source of the stem cells versus the bone marrow as a source of the stem cells. So what's the difference between the two, and when do we use one versus the other? So the most important difference is the adipose tissue has a significantly more quantity or number of stem cells compared to the same amount of bone marrow tissue. And that becomes significant as we get older, because our stem cell counts decrease as we get older. So so whenever we have patients that are older, 65, 70, that's an arbitrary number. We tend to favor the adipose stem cells just because it's a richer source of mesenchymal stem cells. The other difference is that there are some proteins or cytokines in the bone marrow that may not be in the adipose tissue. For example, this protein that we call IRAP, or interleukin-1 receptor antagonist protein, which is a really good anti-inflammatory protein. And that may be one reason why patients who are injected with bone marrow get the relief quicker than the adipose tissue. Bone marrow also has platelets. So it's kind of like getting a PRP as well with the bone marrow. Adipose tissue, on the other hand, its cells are more, they have more longevity. They're more resistant to any stress or hypoxia. So the cells really survive and live really nicely in your tissue. They also have a lot of proteins and cytokines, and some of them may not be in the bone marrow. So how do we differentiate the two? They actually did a study. One of our colleagues did a study comparing bone marrow derived tissue cells and adipose tissue cells in patients up to 75 years old, right, Dr. Rogers, like around mid-70s. Yeah, Mountner study.
Yeah,
and they use 60s for knee osteoarthritis. And the results was that the pain level and the patient function is about the same. So I think for Dr. Rogers and I kind of practice the same way. If the arthritis is more severe, the patient is older, we tend to favor the adipose stem cells just because of the more concentrated stem cell count. If we are planning to inject the bone underneath the cartilage, what we call the subchondral bone marrow, then we tend to favor to use the bone marrow tissue just because there's more studies to support that. So it really depends on your medical history, your MRIs, what your orthopedic condition is with regards to how we decide which one against the other.
Yeah, and it's trying not to make this more complicated than it is, but it is complicated. I mean, even something as simple as will PRP help my knee is a very complicated question to answer. And if you are a person who likes to read the published literature, it gets even more complicated. If you like to read scientific papers, you say, well, this group, on the East Coast found that PRP was very effective and it was better than placebo in this nicely done study. But then this other group on the West Coast maybe didn't show, as good effects. And that's our job as your doctor, to understand the strengths and weaknesses of the scientific papers and why some papers may show a benefit and why others may not. But in terms of treating patients, there are several things that you should ask your doctor about if your doctor is considering PRP. And the number one most important thing is understanding the diagnosis. So for example, I'll be treating a young football player today who has just some mild thinning of his cartilage from a cartilage injury that he had. That's very different than another patient who I'll be treating later this week, who is older and has had significant thinning of the cartilage, but also has some ligament injuries and some complicated meniscus tearing. And so in the younger patient, we can get a very good result, probably better than 80% chance that he'll get at least a year's relief of pain from a single injection into the knee. Whereas that older patient with the more complicated injury, I might actually have to use cells from that patient's fat. And we'll be talking about that in other lectures in more detail about how we do that. And then we might use that in combination with PRP to treat some of those ligament injuries. So there's a science and there's an art, and both come to bear in your care. The other issue is how the technique is performed is very important. So not only is it important that we diagnose you correctly, but that we properly treat all the areas that require treatment with the right kind of product. And so we have quality control in our lab where we measure how many platelets you're actually getting, whether or not there are red cells in that PRP, whether or not there are white cells in that PRP. So that's hugely important. It's also important that your doctor has skills and knows where to inject, right? You do it comfortably and safely. We use ultrasound guidance, we use X-ray guidance whenever we're treating a patient. And then we track our outcomes. So when you say, what's my success rate? I can look at my database of thousands of patients and say, based on your age and based on your problem and your MRI and your X-ray and all these things and what our goals are, this is what we would expect with this treatment versus that treatment. So we have options to discuss. That just to give you a taste of what you should be asking from your doctor and what we ask from ourselves when we deliver care to you.
That's right. So there are questions here on with regards to the cell therapy, if it's just providing pain relief or if it's actually improving the condition. And I think one of the more important reasons why we believe in this therapy so much is they're not just symptomatic relief treatments, but they are also disease modifying. And what I mean by that is they slow down the progression of the degenerative process of the osteoarthritis. And in some cases, it can even improve the condition of the cartilage. It can improve the condition of the meniscus, the soft tissue inside the knee. It creates a conducive joint environment for your body to heal itself better and try to fight the what we call the catabolic reactions or the degrading reactions in a joint that's arthritic. So that provides its longevity and its long-term benefit.
If you think about it, even a cortisone shot can alleviate pain for a short period of time. And there's no regeneration of cartilage from cortisone, obviously, but there is a decrease in pain because you're decreasing the inflammatory response to the arthritis, to the degeneration in the joint. PRP and it gets too complicated to include stem cells in this discussion, but they're all exerting an anti-inflammatory effect. By the way, that anti-inflammatory effect varies from patient to patient. It's probably influenced by your diet. It's definitely influenced by the medications you're taking. It may even be influenced by how much inflammation is in your knee. For example, if I inject PRP or cells from your fat or from your bone marrow in a healthy joint, there's really not going to be any response. Those cells are going to recognize that it's a healthy joint, and they're just going to go their merry way, and they're not going to exert any kind of regenerative effect. So these cells are smart. They sense the environment, and that's one of the reasons we like them over drugs, is because they're acting in a smart way. And we also like the safety profile. We've had very good safety with these treatments. No risk. Well, excuse me, other than the risk of your joint being sore for a day or two after having an injection. That's really the only adverse event that we see. But we should be clear when we say a biologic can modify a disease. If you use the highest standard of the published literature as evidence, nobody has proven that yet. Let's say to the satisfaction of the FDA, but to many of us, we would say there are hundreds of papers that show that PRP, cells from fat and cells from bone marrow, can influence cartilage health, can decrease the enzymes that degrade cartilage, can modify the immune system to decrease inflammation in the joint, make it more favorable to tissue regeneration. Don't forget, your body's always trying to regenerate itself. It's like the weeds in your yard. They just never stop. They just keep doing their thing. As long as they have water and sunshine, they're just going to keep going. The same is true of your cartilage tissue. It's just, it does it very slowly and not very well. And as we get older, that ability is really impaired. And these cells can help restore some of that ability.
One of the injuries that we see most often tied to osteoarthritis are meniscus injuries. And there's a question here with regards to meniscus tears and repairs in the knee. Will these therapies help? There has been some published clinical trials on the use of PRP and fat-derived cell therapy for treating meniscus tears. And with the results of these trials, they have provided not only improvement in the pain for up to 2 years in these studies, but they also improve the quality of the meniscus tissue. So unfortunately, these two injuries almost always goes together, especially in older patients. So we treat both at the same time when we inject your joint. So we inject the joint space itself. And in some cases where appropriate, we also inject into the meniscus tissue.
I've seen a lot of other questions about other body parts other than the knee. Why do we talk about the knee so much? Well, A, it's very common. B, about 90% of the research for PRP and stem cells is done in patients with knee osteoarthritis. Knee is sort of the poster child for all of osteoarthritis, but as many of you have noticed, other joints get arthritis, ankles, hips, shoulders, etc. They don't have as much published papers. It doesn't mean that these treatments do not work. We have evidence from our own patients that they do work. Again, case by case basis, depending on the details of the case. But we can't make general statements about your toe joint or your ankle joint until researchers start publishing those papers.
What would you say, Dr. Rogers, will be our best case outcome for late stage osteoarthritis? Obviously every joint
for
is
worst
different.
case scenario, so we grade knee osteoarthritis, and this is not necessarily the best way, but this is typically how it's done, is based on how your knee x-ray looks when you're standing. So we look at the joint space between your knee. I will tell you as a researcher, it's problematic for a lot of reasons. One, there seems to be very poor correlation between pain and x-ray. We have patients all the time, they have x-rays of both knees and they go, well, my right one's the one that really hurts, but the left one looks worse on x-ray. So x-ray it doesn't correlate very well, but we grade the severity of knee arthritis most commonly based on your x-ray. In our clinic, we also use MRI, because obviously, you can't see the cartilage and the ligaments on the x-ray. So we want to see the whole joint. We want to see, is that joint inflamed, et cetera. So let's take a severe case where somebody can still walk, but not walk very far. Their pain is maybe a 6 out of 10. Their knee is very stiff and swollen. You get the x-ray, it shows very severe arthritis. You get the MRI, it shows very substantial loss of cartilage, but maybe their ligaments are doing okay and their meniscus doesn't look too terrible. So we just have a really severe osteoarthritis case. Just as of this past month, there's been some studies showing that PRP may actually help that patient. There was, I don't know if you saw it, Dr. Umbach, there was a nice study where they looked at patients with severe osteoarthritis and they showed good outcomes.
That's after
which is interesting because
PRP.
typically the papers show that those are harder patients to treat. So it wouldn't be unreasonable to try a PRP first, but typically we're going to find that it's not going to be as effective for the more severe case. And my personal preference is to use adipose tissue. And that's just because it's something that I researched and it's something I've spent 10 years learning. And adipose is preferable, as you heard, to bone marrow in my clinic, predominantly because it's easier to get. There's more of it. And as you get older, you don't lose as many cells in your fat as you do in your bone marrow. And frankly, I find that the results have been better when I use fat. And it's a simple procedure. But what's the best case scenario? If you look at Dr. Mautner's paper, only about 60% of his patients significantly improved when he injected a certain kind of fat product processing method. I think our results are better than that. I would say we're probably about 80% of our patients at 1 year are showing a significant improvement. Significant is a statistical term that I won't bore you with, but it just means that your score on a 0 to 100 score has improved by at least a certain number of points. And then our satisfaction rating is with that patient population is about 75, 80% satisfied at 1 year follow-up. We have patients, I have at least a dozen patients that I treated 6 years ago who are still doing very well. And they had severe knee arthritis and we only treated them once. And 6 years later, they're still doing very well. At some point, they'll need a repeat treatment, but that's pretty good, 6 years from one shot.
Yeah. With regards to repeat treatment, there's questions with regards to how many injections are effective for osteoarthritis. And right now, there's no consensus yet with regards to 1 versus 2 versus 3, or the number of injections that works best. Although in our recent conference, regenerative conference, there has been more and more data to support that the more injections or a series of injections actually shows better outcomes than just one injection. So that recent publication that Dr. Rogers mentioned about is a series of 3 PRP injections for severe osteoarthritis. Typically for severe osteoarthritis, we use cell-based therapies from bone marrow or fat, but this data is showing us that if you use repeat or series of PRP, that it may be helpful. So jury's still out there with regards to the number of treatments. What we do is we give your body a chance to respond to 1 injection, see how you do after a few months. And then if we feel we need a booster shot, then we can repeat the injection as needed.
Yeah, and that's another thing I think that gets overlooked a lot of times in clinics is, the fact that we've been doing this for more than a decade, we have the experience, we know what your response should look like, and we know whether or not it makes sense to do repeat treatment. And that experience helps our patients save money because we're not doing extra treatments that you don't need. We're aware of clinics that just everybody gets 3 shots 1 week apart. I think that's a waste of money. I don't think there's any evidence that, I'll put it this way, there's little evidence that that's the preferred mode for everybody. So I think our approach of, treating you and then seeing how you respond and making a case-by-case determination. But 90% of our patients are not, at least in my clinic, are not getting repeat injections within that first year. There's some questions here about hyaluronic acid. We've talked about hyaluronic acid before. It's a gel-like injection that has been shown to help lubricate the joint, decrease inflammation. There may be even some effects similar to PRP where it promotes some tissue regeneration. There's been a lot of speculation that combining the 2 is a great idea. The studies are mixed. The jury is still out. We have a database where we track results from over 100 clinics around the country. I hope to get further insight from our network of 100 doctors as to what's going to be the best cocktail. Is it going to be PRP for some people, HA for others, combined for yet others? We're trying to resolve that complicated question.
There's also questions regarding cost. So PRP is anywhere from $500 to $1,600, and the cell-based therapies is anywhere from $2,000 to $8,000. It just really depends on how many injections have you done, what body region we're treating. So you can have a financial consult, and our staff will give you all the different detailed cost. We have about 2 minutes, Dr. Rogers. Brian is here. If he is willing to share his experience with us, and which is very, very generous of him. And thank you, Brian, for attending us. If you want to introduce him, Dr. Rogers, I can allow him to speak, and he can give us his experience with regards to his knee issue.
Go ahead and introduce yourself, just since we only have 2 minutes.
Yeah, Brian, I'm going to allow you to talk. So go ahead and share with us your experience. Thank you for doing this.
No problem. Can you hear me?
Yep, we can hear you.
All right. So for anybody listening, my name is Brian Farber. I've been a professional soccer player for 17 years. And I had a rare injury where I had about a 5-centimeter tear down my patellar tendon. And I was due to get a stem cell shot from another doctor. I had been struggling for about 2.5 years to get through it. I tried months of rehab. I tried needling. I tried everything. I had 2 PRP shots elsewhere from other doctors through my team. And just kind of every time I came back from the injury, it would just reopen and it would be the same issue. I ran into a guy on the golf course when I was limping around, and he told me about Chris, and he told me basically I had to see him. And I came in, got my knee checked out, and we decided that I was a candidate for an actual stem cell shot derived from back fat because I couldn't run. I had it.
Not that much, I'll add.
Well, I appreciate that, but it felt like it. So we went through the procedure, and I mean, I tried to come back from this injury multiple times, and within probably 10 days of having it, I was immobilized. I was kind of taking it very easy on the couch for the first couple of days. I knew that I was healing. I knew that it was different than previous procedures, and that my body was actually starting to heal. Within 3 months, I was running no problem. It's like very limited pain, maybe at like 5% of the pain that I had previously. My pain was a constant 8, 9, or 10. On some days when I would wake up, it would just be swollen and hurting. I couldn't run 2 days in a row. I couldn't run with my wife. I couldn't do anything. It was depressing. And playing professional soccer, it was like a career ender. And Dr. Rogers saved my career for sure. And that was, 5 years ago or so.
Yeah, I think it was about 5 years.
Yeah, it got me back on the field. I led the league in game-winning goals a couple of seasons ago, shortly thereafter the injury, and we've won 2 championships since. So
yes,
I feel pretty good. I wanted to come on here and tell my story. For anybody who has questions, I would be happy to be a resource or share my story, because it's very real, it's very accurate, and they did not pay me to come on here. I wanted people to understand that this really will change your life. And if you're struggling with these decisions, you got to go see these guys.
Well, Brian, I really appreciate you sharing your story with us. And I didn't realize you were jumping on the call today. So it's good to hear your voice again, and come in and say hi sometime. I'm glad to hear you're still doing well. A lot of times people think, well, he's a young athlete, he's going to heal. He has amazing stem cells, and all that's true. And what Brian also maybe just kind of glossed over is he worked really hard in rehab after treatment. So I'm a firm believer that it's not just putting cells in the right place, but it's also doing the right kinds of exercise to encourage the tissue to regenerate the way it should. But I will tell you that even people, we have patients in their 80s that we've treated, and even though they're not kicking, goals with a soccer ball, they want to walk, they want to travel, they want to garden, they want to do things and be physically active. And the body is remarkable. I'm just constantly amazed at how well the body can respond when you just create the right conditions for things to happen. It's kind of like, I always equate it to gardening. Again, if you have the right soil, the right fertilizer, the right gardener, and the right sunshine, things happen. And so, not always, but more often than not. And so it's true, regardless of whether or not you're a professional athlete.
And that's the best way to end this amazing discussion. We do have a webinar that we're going to do next month, and we're going to talk in more detail regarding joint osteoarthritis, PRP, cell-based therapy. So watch out for your email and for our post on Facebook. And that's a long 1-hour session, so you can, ask away your answers. We're going to have slides. We're going to discuss this in more detail. So watch out for that. It's going to be first week or second week of next month. But thank you so much for joining us. This has been a great, robust discussion. Brian, thank you so much for sharing your experience. We really appreciate it. And we have some really nice before and after pictures too for Brian's tendon. So if you want to see that, it's also on our Facebook and our YouTube channel. Thanks so much for joining us. Till next time. We'll see you again.
Thank you.